meeting. So we're going to go ahead and get started. Again, welcome to all of you. This is a presentation on level-funded health benefits, a win-win proposition. Our firm, Shepler Fear General Agency, is a general agency specializing in alternative funding and other types of group health arrangements. One of the things that we always are faced with in this industry right now is that health insurance premium costs are rising quite high, and I don't think that's news to anybody on the line. We're still seeing double-digit rate increases this year for a number of carriers, or very high single-digit increases. And for that reason, a lot of large employers have made the decision to drop their traditional fully insured coverage, and they've opted to look into self-funded programs. Again, that's nothing new for many of you. Self-funding has been very popular with large employers for almost 50 years. Employers who go into self-funded arrangements typically state these reasons. They like the fact that they have better cash flow. They many times only pay for costs as they're incurred. They have the ability to retain any year-end surplus, which is another way of saying they feel like they eliminate any carrier profit on their health plan. They have the ability to hold their own claim reserves, and as you know, in a health insurance program, carriers typically under state and federal or state law have to set aside about 20% of paid claims in a reserve fund each year, and that typically will amount up to between 20 and 30% of what the total costs are. Another reason why employers like self-funding is that it avoids state benefit mandates and all premium taxes charged by states because of this ERISA preemption. Let me explain that there are benefit mandates at both the state and federal level, and so while a self-funded plan is exempt from state benefit mandates, it is not exempt from federal benefit mandates. So, for example, certain benefit mandates imposed under ERISA or under the Affordable Care Act, etc., will have to apply to a self-funded plan. And then, as you know, premium taxes charged by the states are also something that they avoid. Federal premium taxes, which are part of the ACA, are charged on self-funded plans, and that's because ERISA was amended to allow for those taxes. And then finally, what the most exciting reason that carriers tend to give is that, or employers give, is that they can custom design their benefits because their benefit plans are subject to federal, not state rules. And so you'll see a lot of employers who set up these self-funded arrangements with some really interesting plan designs. And we could probably do just a course on plan designs over the years for self-funded plans just by itself. But those are reasons why self-funding has grown in popularity. They estimate now that 80% of large employers now self-fund their group medical, dental, vision, or prescription drug benefits. And the definition of large employer in this case is employers with 1,000 or more employees. When you talk about employers with, say, 100 to 1,000, I would say somewhere between 50 and 60% of those employers are self-funding. But really large employers have been doing this for a while, and the vast majority of them use the self-funding on a pretty common basis. Let me just give you a quick overview of self-funding so that we have a point of reference here. Self-funded programs typically include three general cost components. There's the cost of stop-loss insurance that the employer would purchase, which protects their self-funded plan from large catastrophic claims on any one person, and that's referred to as specific stop-loss. And then they would buy coverage that protects them from overall high claims for the group as a whole, and that's referred to as an aggregate stop-loss. Some employers just buy specific only or maybe aggregate only. Many employers buy both specific and aggregate in combination with each other to provide a better ability to temper their risk. So stop loss insurance can be expensive, or it can be very inexpensive depending on how much risk the employer takes. An employer who goes out, for example, and buys a specific stop loss policy that has a $250,000 deductible per person is going to pay a lot less for the employer who buys a specific stop loss that only has a $25,000 deductible. So how much risk the employer wants to take will go a long way towards how much premium they're going to pay for that coverage. The second component of self-funding is administrative services, and administrative services are typically either provided by an insurance company under what's called an ASO, or administrative services only arrangement, or they're services provided by a licensed bonded third-party administrator, or TPA. Carriers have been doing ASO programs for a long time. TPAs have been in business for just as long, and are probably the more popular of the two, because TPAs tend to cost less than an insurance company wants to charge for an ASO program. But you get variations throughout the country. The third part of self-funding, the third cost, is the cost of incurred and paid healthcare claims. And as you can see by this pie chart, that represents the largest percentage of cost in a self-funded plan. You know, stop loss insurance might only cost maybe 25% of the plan, and administrative services might only cost 10 or 15% of the plan. But without question, the incurred and paid claims, the self-funded claims that the employer pays, are the largest part of the plan. And those claims will vary by the benefit design and the use of different managed care networks. And we'll talk a little bit more about that in another slide. Most self-funded plans, as I mentioned earlier, are typically what we call pay-as-you-go arrangement, whereby the employer pays the fixed cost each month. The cost of the stop-loss premium and the administrative cost, they pay that each month based on the number of people who are enrolled, and then they pay the claims as they are incurred. So, of course, of the month, the administrator receives a claim in the mail. They pay the claim, and the employer then funds that. I don't know why that's doing what it's doing, but it's kind of goofy. Anyway, I don't know why that's doing that. Can you guys see that? Yeah. I'm going to try to say not right now. Okay, sorry about that. So in other words, the employers typically will pay the minimum needed to maintain their plan, and they don't build up a surplus of plan dollars. So if they're estimating that their claims are going to be $50,000 each month, they'll pay the claims as they come in, but they won't necessarily put $50,000 into the bank to cover their claims. They'll just fund the claims as they need to. The other thing that's important here is that employers will need to show on their books the liability for incurred but unreported claims, which may be paid after the end of each plan year or after the plan's terminated. So, you know, a typical healthcare claim, you go into a hospital on the first day of the month, and you incur claims over, say, a week's period, but you don't actually end up paying that claim until the hospital sends you out a bill, and that might be a month later. So there's what we call a claims lag in the health insurance business, and that claims lag is something that the employer needs to account for. So if the employer says, I'm going to pay out $500,000 in claims during the year, they probably want to set aside a reserve of about 20% for what we call claims lag, because in the event that they terminate their plan, there will be claims that they have to pay that were incurred before the plan was terminated that don't get presented for payment until after the plan was terminated. So those are important things, and that's just a general overview of self-funding. We could go into a lot more depth, and we're not going to do that today. So the issue is that small employers for years have wanted to look at self-funding and implement self-funding, but frankly they weren't able to. You know, the traditional thinking was that only large employers who were paying $1 million a year in fully insured premium were good candidates for self-funding. Frankly, self-funding can be tricky and it can present some cash flow challenges, and some stop-loss contracts typically would require that the employer had to pay a claim and then get reimbursed by the stop-loss insurer. So if you were a smaller employer, you might have some cash flow issues that you weren't prepared to do. So previously, small employers weren't considered to be a good candidate for self-funding. But in about the last 20 years, that has changed dramatically. When fully insured premium rates, as you know, have exploded. So today, some small, quote, small employers are now paying $1 million or more for annual premium for a fully insured plan. And a small employer, and you're going to see an example here in a minute, that has 130 people in San Diego, their budget for their fully insured plan is $1.2 million a year. So they're a good candidate for self-funding. But also, stop-loss carriers have now introduced products so that employers that are paying as little as $250,000 a year, or 20 grand a month, can actually look at self-funding and consider that as a viable option, because that's a lot of money to them, and stop-loss carriers can now provide products for groups that small. So they developed these new products to attract small employers into the market, and some of the products that I'm talking about are features like what's called a monthly aggregate accommodation, where instead of an annual aggregate stop-loss, they actually have a stop-loss point that is based on a month-by-month arrangement. Another product is called advanced specific funding, where the employer does not have to pay the full cost of a claim and then wait to get reimbursed by the carrier, but rather they pay their deductible. Say they buy a $50,000 specific stop-loss and they have $1 million claim. They just have to pay the $50,000, and then they apply to the carrier, who then goes ahead and funds the other $950,000. There's also coverage available for paid claims runoff. As I mentioned before, incurred but unreported claims. You can buy stop-loss now that will insure that risk as you shut the plan down. And then finally, there are products that guarantee what the employer's terminal liability might be like. So these are all products that have been developed in the last few years to help smaller employers in their self-funded arrangement. So then that brings us to what's called level funding. And level funding is a term that frankly is actually a rebirth of an old idea. Years ago, and I'm talking about back in the 80s and the 90s, insurers offered what was called a minimum premium product. And these were plans that looked just like a traditional fully insured plan, but effectively what they did is they refunded dollars back to the employer in the event that their incurred and paid claims fell below an annual threshold. Today's version of this is called a monthly aggregate stop-loss to prevent adverse cash flow. And today's version generally includes a specific stop-loss with advanced funding, so that the employer doesn't have to worry about a lot of goofy cash flow, problems that, they might not have money to fund. And then today's version of what we call minimum premium, or now level funding, includes provisions for runoff claims that are paid after the end of the plan year. And now what we're able to do is that level funding is now available for groups with as few as 10 employees, depending on the state that they're in. And we'll talk a little bit about what the specifics in California are, but literally there are level funded plans out there for groups for as small as 10. I will tell you that the majority of the groups that we've written in these programs have averaged just under 50, but we have some groups that have as few as 10 participants or 15 participants in their level funded plan, alongside of, say, Kaiser. I think we may have somebody that needs to turn on their mute button. We're getting a little bit of backwash there. Okay, so That being said, again, level funding looks like fully insured coverage. But it is a self-funded program that features this stop loss that we talk about, and it guarantees the employer a maximum cost of coverage. In other words, they can take this to the bank. They can say, look, my worst case scenario is I won't spend more than $500,000 or $250,000 or whatever that number is. That's a guaranteed number. And as a self-funded product, level funding is not regulated by state insurance law. And therefore, it's not subject to state benefit mandates and state premium taxes, just like a regular self-funded plan is exempt from that. Level funding, like self-funding, is subject to federal laws, ERISA, COBRA, TEFRA, and of course the Affordable Care Act. And so the question is, well, why is level funding attractive? Because it guarantees the employer a maximum annual cost, and at the same time it says to the employer, we'll return any surplus to you if your claims fall below that maximum projected level. So it's kind of a win-win scenario. The employer knows that here's the maximum they can spend, and if they have a good year, they get some money back. If they have a bad year, they can't spend any more than what the contract said they would have to spend at the beginning of the year. There's no funny business here. One thing about level funding is that most level funded arrangements use what we call health risk arrangements, health risk assessments. And let me explain what that is. Let's go back to a self-funded plan. And remember, we talked about the aggregate attachment point. The aggregate stop loss is the overall claims limitation for a self-funded employer. And that is generally based on prior year's paid claims. So for example, if I'm a self-funded employer and I have $1 million of paid claims in a year, and I'm just using that as an arbitrary number, the aggregate stop loss will generally reach out and set an attachment point at 125% of that, meaning that I would have to fund up to $1.25 million of paid claims before the aggregate stop loss steps in. That's my risk in that arrangement. And most aggregate stop losses are set at 115 or 120 or 125, and I've even seen some at 150% of what projected paid claims are. The problem is this. Typically, groups without claims experience, and I'm talking about smaller employers, are unable to buy an aggregate stop loss coverage. In other words, you go to the carrier and you say, I want an aggregate stop loss coverage, but you can't show that carrier what you're paying, your past claims have been like. They don't know where to set an attachment point. So they won't sell you an aggregate stop loss. And this was a problem for a long time because small and mid-sized employers really don't have claims experience. Or another example is maybe a large employer or a mid-sized employer that has all of their people on an HMO plan and they don't provide claims experience because it's not a fee-for-service model. So they couldn't look at self-funding because they couldn't show claims experience in order to buy an aggregate stop loss, which they needed to have in order to guarantee that they wouldn't be bankrupt if they had large claims. So what happens is this. In a level-funded program, the aggregate attachment point can be determined through the use of a health risk assessment. And the health risk assessment very simply is this. The individuals in the group complete a health questionnaire. These are confidentially reviewed by an independent third party. The employer doesn't see the information. The broker doesn't see it, anything like that. But those health risk assessment questions are reviewed, and then once they're reviewed, the carrier then says, okay, based on what we can see here, this group has the potential to have X amount of paid claims next year. And let me give you two simple examples. Somebody says in their health risk assessment, I'm taking the prescription drug X, and I'm taking a dosage of, X amount. And generally, they know that this prescription drug is something that they use to treat a certain condition. So they can then project over the next year what that person's going to have in the way of health care claims based on the types of prescription drugs they take. or somebody who's currently being treated for a condition that's going to go on going forward. Again, they will project what based on the severity of the condition, what kind of claims they'll have. So what happens is, after they do this review of the various conditions, they then come back to the employer with a firm attachment point, and that's generally done within 24 to 48 hours after the review is done. And they come back and they say, okay, based on the review that we've done here, the risk of your group is X, and we're going to set an attachment point of, you know, let's just say $500,000 or whatever. They guarantee that. This review process can be done a variety of ways, including a paper review where a person fills out a health risk assessment form, and it's mailed in, sealed mailed into the firm, or they will fax it into a toll-free number. It can be done online, and there are even telephonic arrangements, which frankly are, we think that employers really like that. So the health risk assessment process is a great way for the employer to determine before a commitment's made if they're a good candidate for self-funding. And the good news is it's free. There's no charge to do a health risk assessment. And if I'm sitting down with an employer and he has no idea what his overall claims or health of his group is like, that employer can simply, you know, we can go through this health risk process. You don't know anything about what your conditions are for your employees, but the carrier will come back and say, okay, here's what your risk is like. And the employer may say, you know, that sounds good, I want to move forward with it, or, you know, I've got a high-risk group here, maybe I ought to stay in an HMO plan. Maybe I shouldn't be changing that. So this is we think this is a good tool for small and mid-sized employers to use to be able to get this. Let me talk just briefly about plan designs in these level-funded plans. Again, as I mentioned, most level-funded plans can be custom designed. So it's a choice of different deductibles, co-insurance, co-payments, etc. Most self-funded plans will contract with managed care networks to use, or they'll use the new reference-based pricing or Medicare pricing strategy. Most of the level-funded plans that we work with contract with a number of national PPO networks, including Aetna, Cigna, First Health, and then some of them will contract with some of the local PPO networks throughout the country. And also I would mention that these new RBP, there's reference-based pricing programs, are beginning to roll out across the country, and we're seeing very competitive pricing of these products when an employer decides to use a reference-based pricing strategy in their plan as opposed to traditional PPO. And we'll actually have another seminar probably in a couple of weeks on reference-based pricing and the pros and cons of it. So I know some of you will have some questions about that, but we'll talk more about that at a future meeting. Most self-funded plans, most level-funded plans use consumer-directed plan designs. They put in health reimbursement arrangements, and if you were participating in our call last week where we talked about HRAs and what they're about, almost all level-funded plans that we do now have some sort of an HRA aspect in it. Some of them also have HSA plan designs as well. So both are very good. And then finally, we see wellness and safety incentives and built into these self-funded plans as well. That's going to reward employees for healthy lifestyles and actions. And you know, when you think about it, it makes sense to do wellness and safety things, because if you're on a fully insured plan and you're able to reduce your claims costs by putting in a wellness program, who benefits from that? Well, the insurance company benefits because they're paying out less claims, and yet they'll turn around and still charge you the cost of insurance based on the pool as a whole. And so self-funded employers say, if I put in a wellness and safety incentive plan in here, keeping my people healthier and having a healthy lifestyle, that will show up on my claims experience over time for my plan, and that means that money is something I save. And so that's why these programs have become popular. Let me give you then quickly an example of an employer in San Diego who has 130 people. We just went through a program review with them. They currently offered 2 HMO plans, one with a full network and the other with a narrow network. That plan design was a $1,500 deductible, 75% coinsurance, $2,500 maximum out of pocket. Their rates, the blended rates for the 2 plans together came out to an estimated annual cost of $1.202 million, $1,202,087. Their renewal was going to be about 8, 9, 10%, and that was going to drive them up to just under $1.3 million, so $1.28 million to be exact. So that's what they were looking at with their current arrangement. We came in, showed them a level funded plan, and basically the maximum cost under level funding, if everything went wrong that could go wrong, what came out to $1.194 million. In other words, a little bit below actually what their current cost was. And the breakout of that $1.194 million was simple. The cost that they were paying for specific and aggregate stop-loss premium was about $558,000. The cost for administrative services and PPO network fees and broker commission was about $62,000. And then their claims fund, their maximum claims fund, if everything went wrong that could go wrong, would be $574,250. Now, that claims fund was subject to verification and the overall health risk assessment of the group. And so they would go through, they would do the health risk questionnaires, it would come back and it would say, okay, we're going to guarantee this is the price for your maximum claims. And in this particular case, they've completed that process. So their worst case scenario ended up being about what they were going to pay under their current plan. The key points in all this is simply this. Most, if not all, level funded plans will end up costing about the same as a traditional fully insured plan. There's no magic here. I'm not going to sit here and say, oh, you know, you're going to knock your costs down by 25% in the first year. It's not going to happen. Most of the time, a level funded plan is going to come in at about the same cost of what they're paying now or their renewal. So then why do it? And the simple reason is because they've got the ability to retain their year-end claim surplus. If they have a good year, they're going to get money back. If they have a bad year, they're not going to spend any more than they would have spent if they'd stayed where they were. So that's the key point here. And then, you know, the other key thing is you've got these guaranteed runoff limits. You've got the ability to buy stop-loss coverage that allows for up to a 9 or 12-month runoff of claims. And that's good. I mean, it makes sure that the employer is protected, you know, after the plan is terminated. Even after a year, if they said, I don't want to do this anymore, they've still got a guaranteed runoff. And then they've got various surplus alternatives. In some cases, the carrier might say, look, how about we return to you 2/3 of the surplus, and in exchange for that, we'll agree to lower our administrative fee to you in the beginning. So you've got different types of arrangements where both parties, the employer and the insurance company, share in some of the risk and some of the, quote, profit of this deal. And then finally, the other key point is you can have almost nearly a customized benefit plan with different types of features and provider networks in a level funded plan. And employers really like that a lot. So at the end, we feel that level funding is a win-win proposition. The employer is guaranteed a maximum annual cost through the use of those health risk assessments before any money is exchanged. So they're not going to be trapped in something that they can't get out of. They don't commit to go forward until the health risk assessments are done. And at that point, then if they want to go forward, then they put some money down and they move forward. But they don't do that before the risk assessments are done. So it's you know, there's really no risk in that. The worst case scenario, as I said, they're not going to pay any more than they would have under a traditional fully insured plan. And the best case scenario is the employer has little or very low claims and they get a refund of those unused claims dollars. The employer is able to either duplicate the in-force plan of benefits that they have, or they can incorporate a customized plan that meets their needs. Maybe they want to make a change in their plan and they're not happy with what they've had. It avoids the state benefit taxes and mandates. It has a wide variety of provider networks and administrators. And frankly, to brokers, I would say broker compensation can be just as good as on a traditional fully insured plan. We have the ability to build in a reasonable broker commission that can duplicate what you're getting on a traditional plan. So we think it's a win-win scenario. Let me just let you know that we're pretty experienced in this. We know what we're doing. We're one of the leading producers of level-funded and self-funded programs in California and the Western United States. And among others, we're a big partner with Starmark, their Healthy Choices program. Allied National has a program called Funding Advantage, Marketplace Advantage Level Funding, which is something that we developed recently. The Protect Plan, administered through Meritain, and then Healthy Choices Level Funding, which is a program that utilizes the Aetna network almost exclusively. You need a quote, it's best to contact Jennifer here in our office or our local Shepler Fear sales rep who can put you in the process of how to get a quote done on this. Many times we do the quotes right here internally in our office, so we can turn around a quote to you within 24 to 48 hours of the request. Sometimes we have to send out for the quotes with certain carriers, and that might take 4 or 5 days. But generally speaking, we're pretty quick on this. And then that's how you can get hold of us. So let me kind of open it up for questions. I'm sensitive to everybody's time. Are there any questions that you might have? I know there were a few that seemed to pop up.
I've got a question. I'd like to ask you, is it, if we come to you with a plan that's already self-funded, does that automatically mean that they're not a prospect and we're wasting your time? Do they have to be fully insured?
No. In fact, a big part of our business is to take existing self-funded plans and find them a better price for stop-loss insurance. And we bid that out on a regular basis. We just recently did the Catholic Diocese of Sacramento, and they've been self-funded for many years, and we went out to bid for them and found them a lower cost stop-loss plan. So we do that quite a bit. Good question. Nobody's asked that one before. Other questions?
When you take over an existing plan, do you guys have access to things like network disruption reports?
Are you referring to the reports that the new PPO carrier would provide in terms of who's using what network?
Yeah, or at least, just kind of an idea of, employees, I guess, using, specific doctors being able to, kind of figure out, how much of a change or how much overlap there is with the existing, network.
Yeah, there's a couple of different ways to handle that, and I will tell you, to be honest with you, that we don't do a provider disruption report here in our office. We're not prepared to do that, but what typically will happen is, and here's a good example of, again, a group in Sacramento that recently did this, and they provided us a list of doctors and hospitals that their employees were currently using. We then went to the new PPO network provider and went through and did a check-off to show them which of those providers were in the new network. So in their case, they moved from a blue plan to a Cigna plan, and in most of the cases, the providers were also involved with Cigna. So that turned out, but we would do that on a case-by-case basis.
Are there limitations, like if they have a Cigna level funded plan right now, that they wouldn't be able to move to a Cigna level funded plan, with you guys?
Yes, and what Cigna will do is they'll say, look, if we're already doing this, we're not going to move you to another Cigna network and all. If that's the case, then we would look at a different provider, like for example, I would say about half of the groups that we do in that situation end up moving over to an Aetna network or
Okay.
a First Health network. So we would have alternatives to that. There are I will tell you that there are some cases where the employer makes a statement to Cigna or Aetna, and they'll say, look, we want to keep your network, but we want to use a different TPA. And there have been some exceptions made where the Aetna or Cigna agree, okay, you can do that. But I would say, as a general rule, most of the time they don't want to allow that to happen. So we have other PPO network providers to use. Good question.
As far as reference-based pricing is concerned, I know you're going to be doing a big presentation on that, so I don't want to steal too much thunder. But is there a high potential for balanced billing for employees?
There could be, and that's one of the reasons why we're approaching the reference-based pricing program very carefully, because different carriers, and for example, Starmark just rolled out a reference-based pricing option, and one of the conditions is that the firm that they're using for their reference-based pricing will contract with those doctors to guarantee no balance billing.
Okay.
Okay? And then what they'll do is they'll indemnify the employee in the event that there is an attempt to do balance billing. They'll indemnify the employee against that if that provider had agreed to do so and then reneged on the agreement.
Okay.
I don't think it's, to be honest with you, I don't think it's perfect, but I think it's moving in the right direction, especially since certain large carriers whose names I will not mention have now started contracting in California based on a reference-based percentage of Medicare arrangement. So what you're seeing is that a lot of providers are now being approached by these PPO networks with a reference-based pricing structure, as opposed to the old traditional PPO discount arrangement.
Mm-hmm. Okay.
That is helpful. Other questions?
What about,
very good. Yeah.
What about pharmacy? Is pharmacy typically included in the stop loss and all of that?
Yes.
Okay.
It's included it's always included in the ag. Sometimes it will be included in the spec. It just depends on what type of pharmacy benefit that we're going to incorporate. But for the most part, we arrange to have prescription drug costs included in the stop loss program.
Okay, great. Thanks.
You're welcome. Well, guys, I don't want to go too far over. It's 12:39, and I know I've gone about 4 or 5 minutes over, so I'll apologize for that. What we'll do is we have the names of everybody who participated today, and if we'll do a follow-up email to you and send you a copy of this presentation if you'd like it. We also have recorded it, and we will that will be available if you want to be able to go to our YouTube site and review that one more